Hello and welcome to JNO Live. I'm Seth Kruger, digital media editor at JAMA Network Open. Of course, if you're following along live, send us your questions and comments on Twitter at JAMA Network Open or on YouTube or Facebook in the comment box. Today, we are talking about using Lorenz curves to measure racial inequities in COVID-19 testing. We've got first author, Dr. Alok Modi, with us. Welcome, Dr. Modi.
Thank you so much for having me here.
Great. Well, thanks for joining us. This is a really interesting paper with some very pretty figures, or a very pretty figure, if I will. So first, if you could just tell us who you are, what you do, and why you did the study.
Yeah, so Alok Modi, I'm an assistant professor at WashU in the Division of Infectious Diseases. I'm mainly an epidemiology and implementation science researcher. Prior to COVID, my main focus was on HIV, mainly in sub-Saharan Africa. A lot of my work has been based in Zambia, where we sort of look at a lot of the health system factors in sort of real world HIV care and sort of what are the gaps there, what are ways to sort of intervene on those gaps, but really thinking about in real world settings how things are sort of playing out, not necessarily in trials or sort of in ideal circumstances. So that's sort of what I did prior to COVID. I mean, I still do that. But once COVID came around, I think, there was a lot of interest in sort of applying some of the thinking, some of those skills to what's been sort of happening in terms of like the COVID public health response and where some of these implementation gaps might be. So that's sort of where kind of some of the ideas for this study came about.
Sure. Well, we've certainly heard a lot, and on the show here talked a lot about the inequities in COVID-19 and pandemic across the board, from testing cases, hospitalization, outcomes. And here it looks like the main thing you're doing is looking at testing in St. Louis across socio-demographics. So tell us what you did.
Yeah, well, so just kind of going a little bit back just towards the premise of this, I mean, disparities have been widely documented with the COVID epidemic, and I think fortunately, there's been a lot of thinking as to why that's been happening in terms of, the risk of sort of essential workers living in multi-generational households, the socioeconomic factors, and just sort of structural racism in general. A lot of those factors are deeply important, but I think when we're thinking about sort of the public health response, there are certain things that we're doing, like we're in the middle of the pandemic, we have to do something, we have to act, and so part of what we wanted to think about is like, what are some of the things in the way like the health system and how we're acting and responding to COVID might be making some of these disparities worse, or not necessarily, or just not addressing them. So we really wanted to think about what are the contributions of like the behaviors of the health systems. So that's sort of what led us to think about, okay, let's think about COVID-19 testing, which, at the time when we were sort of thinking about this study, which is sort of in the summer, kind of getting into the fall, it's been one of the most limited resources of the pandemic at that point. There was just not enough testing available, but it's also one of the most critical. You needed to diagnose folks, but in that sense, it's also a preventative tool, because when you diagnose people, you give them the opportunities to self-isolate, to sort of think about ways that they can prevent onward transmission. There's also limitations in sort of who can do what and staying at home, but it does open a lot of avenues. So in general, testing more people does provide lots of avenues for preventing onward transmission, sort of helping to control the pandemic. So we wanted to think about like how are the ways that we're testing people and the testing being distributed contributing to disparities. And I think the way we wanted to look at that, and I think there's no easy answer to like how should you allocate testing when it's limited, when you know that there's disparities in sort of disease burden, death. What we wanted to try to examine from was kind of thinking about what does equitable testing mean, as opposed to kind of what is equal testing. An easy answer is sort of to think about equal testing everywhere. Every community should sort of have a similar amount of tests done per population. But the reality is the disease burden was not distributed in the same way. It was very concentrated in certain areas, not very concentrated in other areas. So from our perspective, equitable testing also really involved thinking about doing more testing where there was the most need. So where there was the highest disease burden. Because if you could think, this is where a lot of the disease is. We need to go in there with more testing, not just diagnose the symptomatic cases, but also identify the asymptomatic ones, or the pre-symptomatic ones where people might have COVID necessarily, and I think about 50% of COVID transmissions are kind of happening in those phases. So you kind of need to have a really robust testing infrastructure and response in these areas where COVID, the disease burden was the highest. So we kind of really framed it from that angle. And what we employed here was a tool from economics called the Lorenz Curve, and a sort of related metrics called Gini coefficients and Hoover indices. But what Lorenz curves do, and they were developed in the economics field in the 1900s, and they're the ways they were originated to sort of understand wealth disparities and sort of how inequitable things were distributed in terms of wealth. And they're the things that give us the sort of metrics like 1% of the population in the United States has 40% of the wealth. Lorenz curves are sort of how we generate those metrics. So we wanted to use that to think about testing. So basically, we looked at the relative amount of testing that was happening in relation to the disease burden across different zip codes in the St. Louis area. And in our study for disease burden, we actually use hospitalizations, kind of think, because testing wasn't widely available, we didn't really know what the true case burden was. We knew how many people were being diagnosed, but hospitalizations might be a better metric that's sort of more proportional to what the true disease burden might look like. Using that, we generated Lorenz curves looking at how testing was just distributed across zip codes relative to the hospitalized cases.
Right. Yeah. And that makes a lot of sense too, because there's so much variation in testing with this totally so much inequity and disparity in the test availability. The case counts aren't going to be really reflective of the cases in the community, but hospitalizations are, you need to be relatively the same amount of sick to get hospitalized across places. It's not objective, but it's relatively equalized.
Right, exactly. That was the thing. And I think, cases are also useful in sort of thinking about this. And we've done another study where we use cases because it's more widely available, but I think hospitalizations probably gets at it a little bit better.
Sure. So if we look at figure A here, the first part, the curve, the main part here,
yeah.
It kind of looks like an upside down area under the receiver operating characteristic curve. It's a little different, obviously, but the idea, if I understand correctly, is if you're at 45 degrees where 1 equals 1, then you're equitable. The proportion of hospitalized cases tracks the proportion of tests, and things would be good. But here we're clearly falling below that line. So what does that mean?
Exactly, and I think you can actually generate the Lorenz curve so it looks kind of more like a receiver operating curve. I think but that's exactly right. Like if things were sort of equitable and sort of the metrics you wanted to look at, we would be doing 50% of hospitalized cases. We would be doing 50% of tests in those zip codes, and that would sort of track that 45-degree line that's there. But sort of when you sort of fall under that curve, and like the more of a curve that you have that sort of relates to the less equitable the distribution is. So in this case, the zip codes are sort of mapped out, and each one is color coded, and you sort of go, as you go across the x-axis, you sort of go through the cumulative portion of hospitalized cases, and then on the y-axis, you're sort of then graphing the cumulative proportion of testing that's happening. So when you sort of look at it this way, I think the closer to the left-hand side of the graph, you think about the zip codes that have 50% of the hospitalizations. Those only have about 23% of the tests that were conducted in the St. Louis area at the time. So that the testing is having less on the zip codes that are on the left side of the graph, and then in contrast, you have the right-hand side of the graph where you have again 50. The furthest on the right-hand side, you have 25% of hospitalizations, but that quartile of zip codes actually had about 50% of all testing. So you're seeing testing is not exactly happening in a proportion to where the disease burden is. Normally with the Lorenz curves, you just sort of get that metric that there is this disparity. But when we color coded the zip codes by their racial makeup, and you can also see the ones that have the higher proportion of Black residents in those communities all sort of fall on the left-hand side, where on the right-hand side they're much more predominantly white. So that's where sort of you're really seeing some of the racial inequities that are coming about.
Yeah, I like the way you visualize this is really powerful, and the fact that the curve itself, if you just look at the curve of the curve, that's basically the exact same thing as the key to what the Black population zip code percentage is at the top, but in the opposite direction, showing that really the hospitalized cases are predominantly in Black zip codes, but the testing is essentially predominantly in white zip codes.
Right. Exactly.
Yeah. Oh, sorry. Go ahead.
Oh, I was gonna talk about the panel B as well.
Perfect. Go ahead.
So I mean, again, there's lots of different ways to look at it, but so this we're sort of seeing that testing across zip codes, there's disparities there in sort of the communities and the zip codes with a higher proportion of Black residents were having less testing. But we also looked within zip codes. So the panel B kind of looks at that same ratio of like how many tests are done per hospitalized case. But then looking at in a zip code, what's happening with the Black residents of that zip code in that community versus the white residents. And so each dot bubble plot on this kind of represents a zip code. It's sized by the population or the number of hospitalizations that happened in that zip code. And again, if everything was sort of equitable, everything would follow that 45-degree line. You'd have 200 tests per hospitalized case in the white population in community, and then you'd also have 200 tests per hospitalized case in the Black residents of that community. But you kind of see everything sort of falls below that line, which sort of again indicates even within the same zip code, you're sort of seeing this disparity between the Black residents and the white residents. So it's sort of there's a geographical disparity that tracks along racial lines, but even within a community, you're seeing similar things happening. Kind of speaking to how intractable some of these issues are.
Yeah. Well, thank you for walking us through this. This is, again, these disparities have been pretty well described throughout the pandemic. This is, I think, a really powerful way to visualize them and show that, we're really falling short when it comes to equity here. And it's just unfortunately such a shame. And, as you mentioned early on with the motivation to do the study, if we just go about, if we use the structures that we have to address the pandemic, we're going to reinforce the disparities that we have.
Yeah.
Same kind of thing. If we use, if we give CVS and Walgreens all the vaccines, the people who have access to CVS and Walgreens, who live near CVS and Walgreens, who have insurance that gets covered there, are going to have the easy access. Than people who work 2 jobs and have trouble with childcare are going to have much harder trouble getting the vaccine.
Right.
Unfortunately.
So like now, instead of, here we did it with testing, but I think this is a fairly simple tool that you can use to sort of track how you're doing in terms of disparities. And I think right now the most pressing issue is going to be vaccines. And, this I think presents a great way to sort of look at it and really think about how we're doing with vaccine distribution. It's almost certain that we're going to see some of the same issues. And I think a lot of proactive thinking and planning to address those and sort of be proactive about like bringing vaccines to where they need to be brought, and where we're going to see the gaps is going to be essential.
Well, I guess to end this on an optimistic note, I think a couple of weeks we'll see some positive steps to try to do better than we're doing now when it comes to equity with the pandemic response. So I don't want to take too much of your time. I really appreciate all the work you're doing here, and hope to see some of the similar work on vaccines as well. And unfortunately, lots of opportunities to do a lot of the same work.
Absolutely, thank you so much for having me.
Yeah, again, thank you for coming on. Of course, this paper is freely available online, open access at jamanetworkopen.com, where you can get all our papers come out every weekday at 10 a.m. Central Time. And, of course, follow us on all these social channels. And join us next week, January 19th at 3 p.m. Central again for JAMA Live. Take care and stay safe.